Meeting of the subcommittee is called to order. Today we're having our final hearing in this series on making healthcare work for American families, and today we'll examine how to get more value out of our healthcare dollars by improving quality and lowering costs. Earlier this week, the Department of Health and Human Services issued a report on rising healthcare costs and the impact these costs are having on American families, businesses, and the federal government. According to this report, the U.S. spent $2.2 trillion on health care in 2007, or $7,421 per person. And this comes to 16.2% of the gross domestic product, which is nearly twice the average of other developed nations. If health care costs continue to grow at the current rate, they will account for 25% of GDP in 2025 and 49% in 2082. Clearly, this level of health care spending is simply not sustainable. So we need to figure out how to change the trajectory of health care costs. Bending the cost curve even in the slightest degree will help mitigate further growth and generate significant savings to our health care system. The difficult part is figuring out how, and that's why we're here today. Part of the problem is how we pay for health care services. There's an old saying that you get what you pay for. In this country, we pay for the quantity of health care services provided, not the quality of the service. So it should come as little surprise that as utilization rates increase, health care costs rise and quality suffers. But this isn't the story across the board. There's a lot of variation in the delivery of health care throughout our nation. In parts of the country, certain health care services are seeing tremendous growth in utilization. Yet in other parts, there are concerns that patients aren't receiving enough of recommended care. So we need to understand better what explains this variation and how it's impacting our healthcare system in terms of both cost and quality. Significant work has been done in this area by researchers at Dartmouth, including Dr. Jonathan Skinner, who we'll hear from today. I think it's also important to note that these problems are prevalent throughout the healthcare system. A lot of people like to point to public programs like Medicare and Medicaid and use them as a scapegoat for healthcare costs run amok. But the challenges we face with costs and quality aren't endemic to just public programs. Private insurers and employers must also begin to rethink the way they pay for health care services. Changes to Medicare payment policies can help drive that change. And finally, I want to mention that we'll also be examining the role of transparency when it comes to the delivery and purchasing of health care services. This has been a priority for our ranking member, Mr. Deal. I agree that consumers have the right to know what they're paying for when they see a doctor or enter a hospital. But that right also extends to other areas, such as purchasing health care coverage. I think we need to be cognizant that transparency, while certainly a good thing, does have its limits. It's not realistic to expect transparency to be a panacea to controlling health care costs. Some, if not most, patients simply won't be in the position to use this information to shop around for the best health care. I want to thank our witnesses for being here today. I'm looking forward to your testimony, and I now recognize Mr. Deal for the purposes of his opening statement.
Thank you, Mr. Chairman. I want to thank you, and I want to thank the witnesses in both panels today for your appearance. Certainly the first panel today will raise a number of issues facing Congress. Chronic care is consuming a larger share of health care spending. Treatment remains uncoordinated and oftentimes duplicative as a result of fragmented care, and escalating costs threaten the coverage of millions of American families. I'm particularly appreciative that the chairman is willing to hold a panel hearing today on the second panel relating to health care transparency. As most of you know, I'm currently making final revisions to my legislation, Health Care Transparency Act of 2009, which seeks to address many of the issues stemming from the exorbitant cost of medical items and services. My legislation addresses a core problem in our health care delivery system which affects millions of American families. Medical bills remain the leading cause of personal bankruptcy in this country, and with these concrete, hard facts in mind, it bears asking why anyone would want to inhibit more transparent, fair price healthcare market, fair prices in the healthcare market. I have some charts, and I'm going to ask if someone would put those charts up while I make a few more statements. While the first reaction of many people in Washington would be to create thousands of pages of new pricing regulations to help solve the problem, I want to make it clear that I believe the best solution would be to simply follow President Obama's call for increased transparency and require any health care provider receiving federal funding to publicly disclose the price they charge to uninsured, to underinsured, and other self-pay patients. Given the efficiencies created in today's internet-based marketplace, particularly as the healthcare industry makes dramatic steps toward wide adoption of HIT and EMR technologies, the task would be simple and would empower millions of Americans with critical information about the cost of their health care. Another equally important component of the proposal would be to require health insurance companies to provide more information to patients before services are rendered. As you know, there are a number of factors which affect reimbursements provided by insurers, such as deductibles, copays, and coinsurance rates, and whether or not the provider is established as an in-network or out-of-network provider. And I think people should know before they receive the services exactly what those services are going to cost. Now, the charts that you see here are pictures made by staff members on a trip to Tanzania, Africa. They're in Tanzanian shillings, and one United States dollar equals approximately 1,300 Tanzanian shillings. Now, the brown chart there is taken at a community hospital in Tanzania, and it's in the chart is located in the front of the reception area at the hospital. As you might be able to translate there, ultrasound there is the equivalent of costing $4 US. Now, that's a little deceiving because GDP and the gross domestic product of Tanzania is very low. The white chart is a list taken outside the outpatient ward at a community health clinic. Now, it seems a little bit surprising to me that in what we would definitely call a third world country, their people going to their health providers have the right to know what the cost of their services are going to be, and they're publicly posted. I challenge you to find very many comparable environments in the United States where these prices are posted for the public to know before they receive the services, and I think that is a shame and something that should be addressed, and we hopefully in this health care reform that we will undertake will have the opportunity to do that. We shouldn't criticize third world countries when they have greater transparency than we do. So thank you, Mr. Chairman. I appreciate your indulgence, and thank you for having both of the panels here today. I yield back.
Thank you, Mr. Deere. Our Chairman Emeritus, Mr. Dingell.
Thank you, Mr. Chairman, and I commend you for holding today's hearing. In the health care reform debate in which we're now engaged, everybody can agree on at least two things. We must reduce the costs of our health care system so that it doesn't bankrupt our families, businesses, and even government at all levels. And we must increase the quality of care so that we can get a better value for our dollar. This means a way must be found to see to it that we can control these costs and reduce the acceleration in growth of the costs that is moving forward. The cost of our health care system is on an unsustainable path, and we must now act to bend the cost curve before it's too late. We have created a system that makes money by running more tests, doing more surgeries, prescribing more drugs, even if the data doesn't back up the particular course of treatment. And of course, it involves buying large amounts of enormously expensive equipment as essentially a business promotion device. One of our primary goals in drafting healthcare reform legislation will be to provide ways to incentivize value of care over volume of care. We must reform our healthcare system in a way that rewards providers for quality healthcare, reduces the number of hospital readmissions, incentivizes primary care, and moves providers in the direction of creating integrated healthcare systems. And wellness must be a concern of ours as we go about this business. We must recognize the need for consideration of evidence-based data in determining treatment plans in an effort to highlight treatments which are most cost-effective. We should not be led to believe that only the most complex and most expensive procedures are the most effective. Most times, this is not the case. Studies show that standardizing certain procedures can save lives. For example, training staff on a simple matter like proper hand-washing procedures is still one of the best ways to prevent hospital-caused infections. Marking surgical sites on the patient's body is another way to reduce medical errors. And this committee has had to address questions involving amputation of the wrong leg or removal of the wrong breast from patients in treatment errors of the most egregious sort. Pre- and post-surgical checklists ensure that patients are receiving the best practices as developed by the medical community instead of a variability in quality of care are a necessity. Finally, we must create greater transparency in the healthcare marketplace. Transparency efforts must include a wide variety of information that allows patients, consumers to make well-informed decisions about insurance plans, services, and providers. A national health insurance exchange could be a very helpful event in this regard. Such an exchange, which would offer a range of private insurance options in addition to a public insurance plan, could simplify paperwork and make the difference among plans, including costs and services offered, more transparent to the advantage of the patients and to the advantage of the system. I look forward to hearing the testimony of our witnesses today about how we can improve the quality of our health care system while also reducing overall costs. Their incitement will be valuable in our meeting of the challenges ahead of us. I thank you, and I yield back the balance of my time.
Thank you, Chairman Dingell. Gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman. One thing great about especially this subcommittee is we have active members who are in the healthcare profession, doctors. We've got Lois, who's a nurse, and they really bring a great benefit of actually being practitioners versus us who are just lay people trying to figure out this very complex process. So I do. I've said it a couple of times. It's really a joy to be back on this subcommittee. I think there is a new concern. Mr. Deal in his opening comment talked about government forcing transparency because we are in the process of being a big payer, and as you see with the TARP and the Wall Street bailout and GM now with the administration being able to tell the CEO to leave, I would expect more of that for anybody who gets government money of any size, shape, or form. I'm not sure this is good for the country, but we are in a new era. And so if you're getting government money, you expect government to start making decisions all the way down. As to one of the bills we had on the floor last night said that we may be able to determine the salary of the janitor in a corporation that accepted TARP money. So figure out how that's going to affect health care in this for the Medicare and Medicaid. And I think you have to look at, because as most people say, Medicare and Medicaid is a driving factor on health insurance reimbursements. So you can't discard the underpayment by the government on these two provisions. I'm not sure how much time. I don't know if I've gone that quickly, but if it is, then I'll yield back if you hit the time right.
All right, thank you. Mr. Green.
Thank you, Mr. Chairman. I want to thank you for holding this hearing today on the health reform and access to care. Currently, there are 47 million uninsured in our country. Overall, health care is consuming an ever-increasing amount of our resources. Health care estimates are now 16% of our GDP, and this rate could hit 20% by 2017, and as our chairman said, 25% later. Current estimates show that we're spending approximately $8,000 per person on health care per year. Unfortunately, we're paying more for the cost of health care, but individuals are receiving less care for their money. Even though we have access to the most advanced technologies, fewer individuals seek treatment due to cost. The current economic times highlight the fact that more individuals are uninsured simply because their companies cannot afford health insurance or the employees cannot afford the premium. Premiums are so high because we have a reimbursement rate policy, including SGR, which does not accurately cover the cost of treatment. We also have a fee-for-service system to reimburse physicians for volume, which often rewards physicians who perform more procedures instead of focusing on better outcomes. As we work to improve our health care system, we hope we will finally address our payment system to encourage better health outcomes and treatment. I believe that this is the root of our high-cost health care and unfortunately prevent individuals from having access to quality and affordable health care. I want to thank our witnesses for appearing today, and I look forward to the testimony. I'd also like to submit on behalf of our colleague, Representative Engel, written testimony for the record from the National Home Infusion Association, Mr. Chairman, and I yield back my time.
So ordered without objection. The gentleman from Pennsylvania, Mr. Pitts.
Thank you, Mr. Chairman, for convening this hearing. As we discuss health care reform, I think we can all agree that patients should be more involved in their own care and treatment. But we will never drive down the out-of-control costs of health care if individuals do not take personal responsibility for their choices and behavior. Too often, though, individuals' hands are tied. In many cases, they do not have the one tool that might arguably be most important to driving prices down and quality up, to helping them make the very best decisions for their own lives, and that is information. What is the true cost of an emergency room visit or a CT scan? What about the same CT scan in the county next door? Of the 2 hospitals nearest my home, which has a lower hospital-acquired infection rate or a lower error rate during surgery? If I'm a self-pay patient, what am I paying compared to the person next to me who has private health insurance? None of us would accept this lack of transparency in other areas of our lives. I can pick up items in a supermarket, compare them using nutrition labels. All the information I need to decide which item is healthiest is right there. We all know that knowledge is power, and that is why I commend Ranking Member Deal on his draft legislation, the Health Care Transparency Act, designed to get consumers the information they need to make informed choices about their health care. Mr. Chairman, I look forward to hearing the thoughts and testimony of the witnesses, and thank you, and yield back.
Gentlewoman from Colorado, Ms. DeGette.
Mr. Chairman, I think this is a very important hearing, and I will waive my opening statement in order to get more time on questioning.
Gentleman from Georgia, Mr. Gingrey.
Thank you, Mr. Chairman. We've heard a lot of testimony over these past few weeks concerning the critical problems our healthcare system is currently experiencing. Healthcare costs are rising faster than inflation and wages, and those costs create barriers to care for many, both insured, underinsured, uninsured, and of course including low-income families and those with chronic illness and the disabled. We do need to fix health care so that everyone has the ability to see a quality doctor or to receive life-saving treatment. We also need to reform long-term care, pay providers based on quality of care they give patients and not just volume. We need to end defensive medicine through meaningful tort reform and support the creation of a complete system of electronic health records. I think this goes hand in glove with my colleague from Georgia, Ranking Member Deal, on his Health Care Transparency Act. This Congress is now on the verge of considering legislation that could fundamentally change the way we access health care in this country. Both sides of the debate want to make our current system of health care better. One side, though, believes that reform should happen through direct government control. The other side, our side, believes that in order to make our system better, we need to fundamentally strengthen what works in health care and strengthen the doctor-patient relationship. My hope is this Congress works together in a bipartisan way to achieve meaningful reform that strengthens the doctor-patient relationship for every American and makes health care accessible and affordable for every American. Thank you, Mr. Chairman, and I yield back.
Thank you. Our subcommittee vice chair, Ms. Capps.
Thank you, Chairman Pallone. Welcome to all of our witnesses, and thank you for taking the time to be with us. Today's hearing is particularly important because it asks the question that is at the heart of our health reform debate. How do we improve the health of Americans while decreasing the skyrocketing cost of health care? The answer lies in how we define and reward health care delivery. We must stop persisting with a complicated, cobbled-together system that really basically treats illnesses. Instead, we need to create a streamlined and comprehensive system which, at its core, strives to prevent illness and maintain health. In order to make that change in healthcare, we so desperately need information-based coordinated care that finds some way to reward prevention is important. This, I believe, is absolutely essential and a way to bring down costs as well. So I look forward to hearing from our witnesses today, and I yield back.
Thank you. The gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. This has been an interesting, very interesting series of 5 hearings, and so you all are the ones that are going to finish this up for us today, and we welcome you all. I especially would like to welcome Mr. Smith, who is on the first panel and has been so diligent in helping me with health care issues in Tennessee, and I appreciate that. And Dr. Herslinger, who has also been someone I've gone to for advice through the years. Because in Tennessee we have had the system of TennCare. And as many of you know and have heard me say during this series of hearings, the mismanagement, very serious mismanagement issues that surrounded this program have caused some serious financial budgetary implications for our state. And I'm one of those that as we have worked through this hearing, it has reaffirmed to me how important it is that we have consumer empowerment, transparency, increased accountability in the health care delivery systems. Without that, we are going to see continued mismanagement of programs such as the TennCare program. Mr. Chairman, I will have to tell you, the hearing title was curious to me, Saving Money, Saving Lives. I wish we had said saving lives while saving money and expecting better outcomes in health care delivery. Welcome to you all. I yield back.
Gentlewoman from Florida, Ms. Castor.
Thank you, Mr. Chairman, and welcome to all of the witnesses. You know, there's this great new technology that's available to members of Congress and others where we can hold telephone town hall meetings, and I did that Monday night. And the call goes out to everyone in your district, and they can just stay on the line or they can hang up if they're busy. We did it on the economy because folks are really struggling right now. And in my community where unemployment's over 10% and we have a very high foreclosure rate, I answered question after question on health care, the affordability. And we did this online poll where people can just press a button, where do you get your health care? And we had we had over 4,000 people on the line, and wasn't very scientific, but most received their health care through their employer-based health insurance. But every question was how we just can't afford it any longer. It's out of control. The parent who had health care through the employer, but their son was prevented because of a pre-existing condition from participating. Left them out, just completely out in the lurch. The retired school teacher who still has the benefit through the school district is struggling with how to pay for prescription drugs. And that really hit home because that morning I was at a community health center with a pharmacy that had 340B pricing, the lowest, and I can't rationalize the difference there. So this is the front burner issue, and I look forward to your expert testimony and how we make health care more affordable for Americans. Thank you.
Thank you. Gentleman from Texas, Mr. Burgess.
And I thank the chairman. We do have really a distinguished panel, 2 panels before us this morning. Of course, Dr. Goodman from down in North Texas. Being a representative from Fort Worth, I won't say Dallas, but nevertheless, I'm so glad to see you here because I think your wisdom will be great. Dennis Smith obviously has been a great help to me in crafting some of these things. Dr. Cassell, we've crossed paths numerous times before and certainly appreciate your testimony this morning. Dr. Herslinger and Ron Bachman, appreciate you being here as well. I support transparency and competition. I think our efforts must not drive behavior into the shadows, but should truly try to better our care and empower the patient. If we want to move into a robust system of consumer-directed health care, clearly transparency is going to be a critical issue. I had introduced legislation on this in the last Congress, and perhaps we'll do so again. I realize it is a somewhat contentious task when you're dealing with all the stakeholders, but I do believe it's worth the effort. Just a word on comparative effectiveness. I think we need to be realistic about how we use comparative effectiveness. Realistically, we need to use it as a reference for how physicians treat their patients, but it should not supplant the individual physician's judgment as a hard and fast rule for healthcare delivery. Let us not forget when Medicare was introduced in 1965 that in the statute itself, it said nothing in this legislation shall construe that the Medicare legislation will interfere with the doctor's ability to treat the patient. I think we'd be wise to keep that in mind today as we go through this. I'll yield back the balance of my time.
Thank you. Gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Mr. Chairman. I just wanted to point out that no longer is the problem of the cost of health care, access to health care, reserved for the 47 million people that don't have health insurance, but is really affecting so many more. First, we know that only giving someone an insurance card is not going to fix our health care problems. The Commonwealth Fund estimates that 25 million insured people can't afford the gap between what their insurance covers and what their medical bills demand, and that number is growing exponentially every day. Second, in 2007, health care accounted for 17% of our GDP, but our healthcare system ranked last or next to last on 5 dimensions of a high-performance health system: access, efficiency, equity, quality, and healthy lives. And so we have to be starting to pay for quality care. And finally, I want to talk about transparency. With all our current technological advances, there's no reason why we cannot access information about insurance practices. As Diane Archer will outline in her testimony, it's impossible to hold insurers accountable without knowing, for example, how they calculate premiums and other cost-sharing requirements, their denial rates, loss ratios, their prescription drug rates, or the in-network versus out-of-network care rates. My office recently met with a group of insurance agents who complained of being unable to get this type of insurance from insurance plans. That was insurance agents. How can insurance agents accurately represent and sell insurance products if they don't have all the relevant information consumers need to make coverage decisions? We can create a system that's not only accessible, one that's efficiently and properly focused on providing quality care. Thank you, Mr. Chairman. I yield back.
Thank you. Gentleman from Iowa, Mr. Braley.
Mr. Chairman, thank you for holding this hearing on the issues of cost and value in our healthcare system. Creating a healthcare system that emphasizes quality of care over quantity of patients seen has been a long-standing priority of mine. Studies regularly show that the state of Iowa ranks right at the top of our nation in terms of quality of care, but Iowa healthcare providers receive some of the lowest Medicare reimbursements in the country. The current fee-for-service system incentivizes the quantity of patients seen over quality of care, which results in higher costs and an emphasis on the bottom line rather than patient outcomes. A system that provides clear incentives for quality of care would also improve access to care for patients in rural America. Despite the well-documented success of Iowa's healthcare system, Iowa healthcare providers lose millions of dollars due to outdated geographic practice indexes. These antiquated figures ensure that some parts of the country receive drastically lower Medicare reimbursement rates than other parts and have led to a shortage of doctors and medical personnel in rural America. There's already a physician shortage in Iowa, and the existence of these gypsies provides further disincentives for treatment of those who need it most, Medicare patients. We need a system that emphasizes quality, efficient care with value-based measures. This will reduce costs and improve America's quality of care. And I'll yield back.
Thank you. The gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. I really want to commend you, Mr. Chairman, for this series of hearings that you've held making health care work for American families. We've touched on a wide array of issues of great importance as we look at national health care reform. Over a period of a few months, President Obama, during the transition, invited Americans to host and participate in health care community discussions to talk about how to reform health care in America. And these discussions showed that more than anything, Americans are worried about cost. And this is no matter whether they have insurance or not. The financial burden of health care is a daily concern. It's something that keeps them up at night. This situation obviously cannot persist, and we have this tremendous opportunity in front of us right now to reform our system and rebuild it for the next generation. And Mr. Chairman, I look forward to the opportunity to work closely with you over the coming months to produce comprehensive health care reform legislation that addresses these very significant concerns of our constituents. So thank you for this series of hearings and our hearing today. Thank you to our witnesses.
Thank you. Gentlewoman from Ohio, Ms. Sutton.
Thank you very much, Mr. Chairman, and thank you for holding this important series of hearings. Today's hearing, Saving Money, Saving Lives, will address the cost of health care and transparency in our health care system. You know, we're all aware that American health care is the most expensive in the world. The Kaiser Family Foundation's March 2009 report on health care costs notes that the U.S. spends 90% more than any other industrialized country on health care. With such high costs, one would think that our healthcare system would be exceptional. But as indicated in previous hearings, there are serious access issues in this country, resulting in 47 million Americans without health care. Families USA estimates that each day in Ohio, 2 Ohioans die because they lack health coverage. I look forward to hearing from our panel today as they address ways in which our healthcare system can cut down on costs while maintaining and even enhancing quality. I also look forward to hearing from our panelists as they address the role of transparency in our healthcare system. And I thank you again, Mr. Chairman, and yield back my time.
Thank you. Our ranking member, gentleman from Texas, Mr. Barton.
Mr. Chairman, I'm just going to submit my statement for the record, but how can we oppose a hearing entitled Making Health Care Work for American Families, Saving Money and Saving Lives? Can't get any better than that. So,
thank you for the compliment on our message.
Glad to be here, and I want to especially welcome Mr. Goodman, who's a good friend of mine, and we're glad to have a conservative viewpoint on this panel. Thank you, Mr. Chairman.